Hi, I'm Stephanie Hertz, Marketing Director here at Warwick Forest Retirement Community, the premier sponsor of CNU's Lifelong Learning Society. I'm in the private formal dining room here at Warwick Forest Independent Living, and this room can be reserved by our residents to host private dinner parties. Today, I have the pleasure of introducing Dr. Elsie Achieng of Riverside Health System. Dr. Achieng earned her medical degree in 2013 from the Morehouse School of Medicine in Atlanta. She subsequently completed a neurology residency at the Ohio State University, remaining there to complete a sleep medicine fellowship. She completed an additional fellowship in clinical neurophysiology with a focus in electroencephalogram and epilepsy at the University of Maryland Medical Center. Dr. Achieng is board certified by the American Board of Psychiatry and Neurology. Dr. Achieng's longtime fascination with the function of the nervous system inspired her to pursue a career as a neurologist. She is passionate about diagnosing and managing neurological conditions with particular interest in sleep disorders and epilepsy. Dr. Achieng works hard to help her patients, caring for them with the same compassion and respect that she would extend to her own family. Originally from Nairobi, Kenya, Dr. Achieng enjoys living near the beach in Hampton Roads with her husband. Her favorite pastimes include traveling, cooking, and painting. Today, Dr. Achieng will be talking on awareness of sleep disorders.
Good morning, everybody. So we'll be talking about sleep disorders, but in a way, I wanted to just go through the defining what sleep is, go through the different stages of sleep, and then we'll review how we regulate the sleep-wake cycle. And then through each stages of sleep, we're just going to take a pause and go through pertinent features of the different sleep disorders, focusing mainly on the common sleep disorders. And then if we have questions about them as we talk about that, you can feel free to ask me. And then we'll finish off by going through the effects of lack of sleep or sleep deprivation. So sleep is a state where it's reversible, and we have decreased responsiveness, movement, and even our metabolism changes. And it goes through cycles through the night, and we divide it into different stages. So we think of it as non-REM sleep versus REM sleep. And during the non-REM sleep is the first 3 stages of sleep. You can hear people say light sleep, and deep sleep is into that, and we'll go into detail. And we stage these based on the brain electrical activity through the electroencephalogram, sensors that detects eye movement and muscle tone during a sleep study. And then it's just a cycle through the night. It can be up to 120 minutes, and each REM sleep stage occurs every 90 minutes. And the REM sleeps happen later in the night or early morning hours. So now we'll just go through each stage. And again, we'll just pause during pertinent stages and talk about different sleep disorders as it relates to this sleep stage. So before you go to sleep, we're first awake. And the way we tell this is based on what the person is doing behaviorally. Person is alert, eyes are open, could be talking, but we can also tell when somebody's sleeping based on when they're laying there with their eyes closed, based on the brain activity. And this is just how fast the brain waves are moving. And when it's in the alpha rhythm, it's a specific frequency, 8 to 13 cycles per hour where the brain activity is going at. And this picture here is just a sample of EEG. It looks like a bunch of squiggly lines, and the bottom part here, I don't know, it looks like a brush. The best way to try to explain it. You can see this brushy That's at the bottom here. So that's a fast frequency. This part here, when I look at it, I know that this person is awake. Okay. And then next to the first stage of sleep, so we awake, we become drowsy. So stage 1 is the transition from wakefulness. And it usually doesn't last long. It could be 1 to 5 minutes. Out of the entire night or the sleep period, it's 5 to 10%. If somebody's woken up from this stage of sleep, they don't feel like they slept at all. And then again, this is when the brain activity starts to slow down. And this is just technical term that we use when reading at the EEG part of the sleep study, where the amplitude goes down, there's different wave frequencies, and then the eye movement starts just rolling. And again, this is just a sample EEG, and it just doesn't look as dark as compared to here. We see a change at the end of this picture here, where it's as dark as it was in that previous picture during wakefulness. So it's just less lower amplitude, mixed frequencies, and then up here is the sensors for the eye movement, and it's just we start seeing the eyes rolling. So the next step will be stage 2 sleep. So this stage takes up a majority of the sleep cycle, up to 50% of the total sleep time. When we look at the brain activity, there's certain brain waves that gives us a clue that this is the second stage of sleep, and we call these K complexes, this check mark looking brainwave here, and then the sleep spindle is much faster than the alpha frequency. So these are the clue that the person is in stage 2 sleep. Again, this takes up a majority of the sleep cycle. And then if somebody is taking certain medications, like clonazepam, Ativan, Xanax is a common benzodiazepine prescribed, that can increase this stage. And then the body also goes through changes at this point. Our body temperature starts to drop, heart rate begins to slow down, but it's in a regular manner. And then that third stage of sleep, we call this slow wave sleep. If you ever heard of deep sleep, so this is the stage of sleep that we are talking about. It takes up to 20% of the total sleep time, and this happens earlier, more so earlier in the night, first half of the sleep period. And the percentage of this sleep decreases with age. And as we get older, we have less stage 3 sleep and increased wakefulness during sleep. And if somebody is sleeping and they enter this sleep stage and you try to wake them up, it's harder to wake up a person from this stage. On the EEG, there's even slower brain activity. So technically we call it a low frequency, high amplitude brainwaves. And then this part is where the body physiology changes even further. So when we talk about heart rate and blood pressure decreases during sleep, this is the stage where it happens the most. It could be up to 10 to 20% decreasing. Also, the restoration of the body for the next day, and it's important for the memory consolidation occurs in this stage. And then this is the part I'm going to take a little pause to talk about sleep disorder that involves movements out of sleep or certain behaviors out of sleep, and they tend to happen in this stage of sleep. So we call that parasomnia. So a parasomnia is a sleep disorder that consists of unusual or undesirable events or experiences that disrupt sleep. And these are just the example of these non-REM parasomnias. And just basic features of these, sleepwalking, common in children. They walk or perform different tasks like going and opening up the fridge or trying to get out the door. Some people, it looks like they're doing something like they're awake, but they're actually sleeping. And then there's a sleep-related eating disorder where out of sleep, they might eat unusual foods. So it's not just getting up out of sleep and eating a typical food that you would eat during the daytime. This is somebody would get up and start eating butter or something that just never eat and it can be dangerous. They may eat toxic substance. Then there's sleep terrors. This is also common during childhood. And this one, the child can wake up screaming, crying, and during that time, they have like a panic. It looks like a panic reaction when they have a rapid heart rate, breathing really fast, sweating, then last seconds to a few minutes, and they go back to sleep and they don't remember it. This is different from nightmares, which occurs out of REM sleep. So we call that a REM parasomnia. And typically with this one, out of the nightmare, they wake up similar symptoms, but they have very vivid dreams and they can remember the details of the dream and they remember waking up out of it. And then there's a confusional arousal. If you can remember that during stage sleep, it's really hard to wake up somebody from that stage. So confusional arousal, the person appears awake, but is confused, disoriented, may not know what time it is, what day it is. It may take a bit, a few minutes to an hour or so. You have trouble answering questions. And again, this can last a few minutes to an hour. And it can be common in childhood. We don't see it as much as we get older. But of course, you can have a confusion arousal if you have certain sleep disorders like sleep apnea. So now we're into the last stage of sleep, REM sleep. Back before they used to call deep sleep as stage 3 and 4, but now it's just stage 3. So it's stage 1, 2, 3, and then we go into REM sleep. REM sleep takes up to 23% of the total sleep time. And this is the part of sleep where people have vivid dreams, and it occurs later in the sleep cycle. We tend to see this more earlier in the morning, later in the sleep period. And we stage this based on brain activity. So the brain activity, we saw that in stage 3 sleep, the brain slowed down quite a bit, but then now with REM sleep, the brain picks up again and is quite active. Similar frequencies are used even during wakefulness. There's rapid eye movements, and then the body's physiology also changes here. So we had a decrease in blood pressure and heart rate during stage 2 and 3, especially stage 3. But in REM sleep, the blood pressure goes back up, heart rate increases, the breathing becomes irregular, and this is a part that also memory consolidation happens. And then the way we tell somebody's on REM sleep, in addition to the rapid eye movements and the fast brain activity, is there's lack of muscle tone. So we call that a REM atonia. So all voluntary muscles except the breathing of the diaphragm and then the eye movement, it's paralyzed. But this tone comes back up during wakefulness. And this is just a sample EEG of how the top sensors here. So the eye movement, we see fast eye movement. The brain activities, starting to get dark again as it is during that wakefulness. But specifically, these eye movements tells me just by looking at this EEG that this is REM sleep. Then now we're gonna take a break from that normal sleep architecture and the changes that happen during sleep and talk about these sleep disorders as it relates to that sleep stage. So sleep apnea is a condition that happens during sleep where the breathing stops or slows down. And obstructive sleep apnea is the most common type of sleep, is one type of sleep apnea. And this is due to the airway being blocked off, either partially or completely. And then I just put on here how we rate the severity of sleep apnea. So mild obstructive sleep apnea, you would have 5 to 15 breathing pauses per hour of sleep. Moderate sleep apnea is 50 to 30 breathing pauses per hour of sleep. And then severe sleep apnea, obstructive sleep apnea, is more than 30 breathing pauses per hour of sleep. So during REM sleep, if somebody has sleep apnea, especially obstructive sleep apnea, when they sleep and they go into REM sleep, their sleep apnea is worse at that point. Because if you think about it, back to the REM sleep slide, we mentioned that there's lack of inactivity of muscles in the body. And so the muscles that's keeping the airway open, these are further relaxed. So that worsens the airway blockage. And then with deep sleep apnea, when there's blocked airflow, body oxygen level drops. Our brain detects that to send a signal to your breathing muscles to open up the airway again. But during REM sleep, it takes longer for the brain to respond to that. And so these breathing pauses last longer. So when we get a sleep study, we usually ideal sleep study would include REM sleep in it so that we can get the most accurate diagnosis of the sleep apnea, especially if the person is also having a treatment for sleep apnea with CPAP and you want to titrate the CPAP and see the best pressure to treat them on, we'd really look at that pressure settings during REM sleep because we want to use the CPAP pressure that eliminated these breathing pauses during REM sleep, because this is when the sleep apnea is worse. And then another sleep disorder that you would think about in relation to this REM sleep. So narcolepsy is a condition that is consistent of excessive daytime sleepiness. And it could be from a lack of a brain chemical neurotransmitter that promotes wakefulness, or some people just have it without having that known decrease in that neurotransmitter. So the symptoms are excessive sleepiness. They have sleep paralysis, sleep-related hallucinations, where going right into sleep, they might see shadows or see things that are not there, or same visual phenomena can be seen when they're trying to wake up out of sleep. And then cataplexy, and that's brief periods of muscle weakness when exposed to strong emotions. Typically with strong laughter, the person can fall to the ground or just feel weak in the arm, and it lasts seconds. And so the feature of narcolepsy is that these individuals enter into REM sleep early in the circle, or they immediately go into REM sleep, especially even if when they're taking a short nap for 20 to 30 minutes, they go straight into REM sleep. And if you can think about REM sleep, that's when the body muscle tone is decreased. So they have this sleep-wake intrusion. So the sleep paralysis part, if they're waking up while the body is still in that waking up from that REM period, you can understand why they would feel scared that they cannot move from where they're sleeping. So that's what we call sleep paralysis. And then going back to the parasomnia, so there's a parasomnia called REM sleep behavior disorder. And so this is basically a condition where the person acts out their dreams. And it's usually unpleasant dreams. They could be kicking, punching, thrashing, and they remember dreaming about whether it's being chased or fighting or just something violent. And they may even get up out of the bed and try to run. And end up hitting themselves on the wall or falling onto the ground. So it can be associated with significant injury, or they can just be making loud noises, shouting. And the feature for this REM sleep behavior disorder, they don't have that loss in muscle tone that typically happens in REM sleep. So because muscle tone is just the same as it was when doing wakefulness, they're dreaming, they end up acting out their dreams. We don't really know a specific cause for this, but we see it associated with risk of developing certain neurodegenerative conditions like Parkinson's disease, a type of dementia called Lewy body dementia, and then a condition called multisystem atrophy. So now that we've talked about sleep stages, what we see during sleep, and certain conditions as we relate to those different sleep stages, I wanted to talk about other sleep conditions. So insomnia is pretty common sleep disorder. And it's typically basically a condition where a person has difficulty initiating or maintaining sleep. where it takes more than 30 to 60 minutes to fall asleep, or they frequently wake up through the night, or they wake up too early despite having adequate hours of sleep. So if you can't really say you have insomnia when you don't get the opportunity to get that adequate hours of sleep. What I commonly hear is I try to go to bed at 9, 10 o'clock. I don't fall asleep till 1 or 2 in the morning, and then I'm out of bed by 8 o'clock. So they had adequate hours to sleep, but just they can't fall asleep or stay asleep. And so there's different causes for this. So just mainly it's related to a lot of different conditions, medications, or just some people just have a primary insomnia where they just cannot have a difficulty sleeping. We call that, it's not because they have psychiatric condition or medical condition like chronic pain. It's just they just cannot sleep. And so we diagnose this as a disorder, though, based on having dysfunction in the daytime. Just because I couldn't sleep last night preparing for a lecture doesn't mean I have an insomnia condition. So usually the daytime function is people report having fatigue in the daytime, poor concentration, attention, mood changes. You see this a lot, where most commonly like irritability, different types of mood, depressed, just not being able to function in the daytime, daytime sleepiness, difficulty finishing tasks at work or school, especially worried about sleep. It's this a lot. People who have insomnia, they just constantly worried about sleep. And then with children, the symptoms can be different, where they're very hyperactive and impulsive. And so now the circadian rhythm. So the circadian rhythm is different changes in the body that occurs in a 24-hour cycle. And basically it's controlled by a clock in the brain located in this area called the hypothalamus. We call that the suprachiasmatic nucleus. And that uses light and darkness of the environment to control sleep-wake cycle, among other things, hormone secretion or body temperature, wakefulness. And other clues that the clock uses to control this rhythm include feeding, being active, social activity, all these are clues to promote wakefulness. And so when we think about this sleep-wake cycle, we think of a circadian clock system that controls or tries to align our wakefulness and sleepiness based on the night and day cycle that we're in the environment. And then as we are awake, there's a process called a homeostatic drive for sleep, our need for sleep that builds up the more we stay awake. So these two processes interact with each other to promote, to influence our need for sleep. And that kind of goes into that insomnia, where it could be just a misalignment of the process, or depending on the time the person ends up sleeping, this system, the clock resets itself. You can kind of have this cycle, comes in cycles. Some nights are better, some nights are worse. So when these two are misaligned, it can contribute to a lot of sleep disturbances. So this is just, again, just a picture to go over the overview of how the different systems interact to influence our need for sleep and promote wakefulness. So in the brain here, that's where the master clock is. And it, when it sees light, sunlight is the strongest influencer of promoting wakefulness. It sends signals that block melatonin secretion, and that promotes wakefulness. And then when it sees darkness, like in the evenings and at night, it sends signals that eventually leads to the melatonin being secreted and creates this system that promotes sleep. So again, this is just that two-process model of sleep that I was talking about. So at the bottom here is the process C. So that's the circadian clock. You know, when looking at being influenced by the circadian clock matching up with the environment, depending on the night and day cycle. So when it sees light, it promotes wakefulness. So, you know, when somebody wakes up in the morning, the heart-stillating level in the morning. And then as we are awake, there's a process also building up to promote sleep. And then in the evening, that circadian process, that darkness promotes sleep. So that alerting system goes down, and then the sleep pressure is being used up in the evenings. And then the same cycle. So it's just a night and day cycle, depending on the exposure to sunlight and darkness in the environment. So when these two processes are misaligned, we see different symptoms and disorders that can stem out of it. Of course, we talked about insomnia, which can be a symptom of all of these. So we call these circadian rhythm disorders. And we call it, again, for something to be a disorder, it has to be associated with a dysfunction and symptoms. So insomnia is a complaint. Some people have excessive daytime sleepiness and just difficulty functioning through work, social functioning, and just lack of sleep can affect our thinking and memory, and we'll go into that as well. So go to the next slide so I can explain these disorders. So with advanced sleep-wake disorder, a person with this type of disorder would feel sleepy earlier than their desired bedtime. And then the body's clock is set up at an earlier time than their desired bedtime. And then it's set up to wake up earlier than the desired time out of bed. That's the opposite. And we tend to see this as a sleep cycle changes, and it's common among older individuals versus the delayed sleep-wake phase disorder is common among young children and adolescents. So with this one, the body's clock is set to sleep at a later time than a desired bedtime. So you can see here, somebody might want to try to sleep by 11 midnight so they can make it to school or work on time, but their body clock is set up to fall asleep much later and wake up much later. The non-24-hour sleep-wake rhythm disorder, it's commonly seen in people who are blind because they cannot detect that light signal. So their circadian rhythm doesn't really become sync with the environment. So their sleep cycle is progressively delayed to later and later and later in the night, even back up to the day. Irregular sleep-wake rhythm disorder, they don't have a specific time. They're just bouts of sleepiness throughout the 24-hour sleep period. And then shift work disorder also falls under these, circadian rhythm disorder, as well as jet lag. So if your body is used to a specific time zone and then you travel to a different time zone, your body clock is misaligned with that time zone. Any questions about all this? A lot in 2 slides. All right, so now that we talked about sleep and the sleep-wake cycle and the importance of lightness in the daytime and darkness in the evenings to help us regulate that sleep-wake rhythm. So how much sleep do people really need? I know most people hear that, oh, you absolutely have to have 7-8 hours of sleep each night. But that depends. It depends on what hours of sleep the person needs to make them function in the daytime and be alert enough and not have any. So there are some people who are short sleepers and they can sleep less than 6 hours and they're fine. They've done that all their life and they have no issues, no health, cardiovascular health issues, no sleepiness, no car accidents. They function through the work, they're just fine. And then there's some people who are long sleepers and they need more than that required hours of sleep, 10, at least 10 hours. And if they get less than that, they cannot stay alert. They have a hard time completing tasks. And we see that most children require more hours of sleep than adults. So the Academy of Sleep Medicine recommends 7 or more hours of sleep per adult. I like the Sleep Foundation recommendation because it takes into account the various sleep needs for different people. So, and this is a chart of recommended sleep hours through the ages. And you see in infancy and childhood, the recommended hours of sleep in blue here are much more than as we get older. So most adults is between 7 to 9 hours, but some people need more. So acceptable ranges, 10 to 11 hours, and some people do okay with the less hours. But less than 5 or 6, that gets into that danger zone. So when we say sleep deprivation, what do we mean? So it's just a sleep that doesn't support adequate alertness, performance, and health. So typically for most, it's getting less than 6 to 7 hours of total sleep time per night. And this could be just because of poor sleep quality. We talked about different sleep disorders like sleep apnea that can disrupt sleep. So just going back to that, the airway becomes blocked off, the body oxygen level drops, and then the brain detects that and arouses the person to wake up. And it's not fully awake, they just go back to the wakefulness stage so that the air can come in. So they really never get to that stage 3 REM sleep and they wake up feeling tired and exhausted the next day. Or it could be just reduced total hours of sleep. And it could be acutely, like few days during the week, or it could be chronically sleep deprived, where depending on the situation, whether it's work or social, the person just doesn't get enough sleep. So we divide that into either whether it's acute or chronic sleep deprivation, it does have some negative health consequences. Can go back to the stage 2, 3, especially 3 and REM sleep. It's really important for memory consolidation and restoration for the next day. So with less sleep, there's data showing there's cognitive impairment where you can have this decreased reaction time, poor attention, difficulty completing complex tasks, errors at work. Scary part as well is not having enough sleep can have excessive daytime sleepiness. So that's drowsy driving, mood changes. So irritability, poor judgment, and then some data are reporting that the effects of sleep deprivation are noticed. There's like a circadian pattern to it where the effects are more obvious either early in the morning or late at night. I'm not really sure why that is, but we just know there's a circadian pattern to these effects. And typically people can recover if they've had regular adequate hours of sleep the nights leading to that. And then if this is a chronic issue, again, prone to drowsy driving, car accidents, workplace errors. Of course, this affects ability to do things that you typically enjoy, can have conflicts with work. And then the health risks for sleep deprivation include diabetes, obesity, high blood pressure, high cholesterol. It also affects immunity. And they've seen increased inflammatory markers. So when there's an increase in inflammatory markers in the body, it can lead to a series of pathological changes that eventually can contribute to coronary artery disease, such as if there's inflammation, there's a plaque can form in your blood vessels, and that can make the blood vessels tighter from plaque formation. And then people who have sleep deprived have been shown to have like susceptible to infections like a common cold. Some reports have reported reduced response to vaccination. So there's an effect in the immunity as well with the lack of sleep. And then I was just going to finish off by going through, again, talking about the sleep hygiene. I was asked about, with insomnia, why does it happen in cycles? Again, that just depends on the sleep-wake timing, exposure to light, and how long we've been awake. So these are the common recommendation you would see in a clinical setting, or people talk about as sleep hygiene. So these are just tools that we should follow to help us regulate that sleep-wake cycle and get an adequate, help us sleep at night and be alert in the day. So things like maintaining a routine bedtime and rise time. So having a consistent time in bed and time out of bed helps your body synchronize to the night and day cycle. Avoiding naps later in the day, especially those lasting longer than 1 hour. Again, taking a nap in the daytime takes away from that sleep pressure that was building up when you're awake. So, and that has the potential of resetting your body clock to a later sleep time. So taking a nap in the daytime makes it hard to fall asleep at desired sleep time at night. Caffeine, the reason why we say avoid caffeine is that it interferes with this neurotransmitter that the body uses to promote sleep. So it blocks, we call it adenosine, so it blocks that receptor. So that can explain why when you take caffeine, it makes you awake, gives you energetic, and it disrupts sleep. Some people use alcohol before bedtime to try to help them sleep, which is initially sedating, but it disrupts sleep later in the night. Nicotine has the same effect as caffeine. Exercise is recommended because it promotes sleep later in the night, but just try not to do it too close to bedtime. Again, keeping the environment at sleep time very quiet and dark, as we saw with the circadian rhythm. Darkness promotes sleep, light promotes wakefulness. So when you're exposed to light from the TV, the room light, electronic devices, all these things, that part of the brain is seeing that and is sending signals to promote wakefulness, and that can reset your time to sleep at a later time, which most people do not want that. And then other things that the bedroom clock, most people with insomnia can have a tendency to do this, where you're laying there, can't fall asleep, become frustrated, so you keep watching the time. And that just makes it even harder to fall asleep. So we recommend people to avoid watching the clock. And then thinking about the clues that the body uses to sync the clock with our environment. Besides the light and dark cycle, eating in the evening is kind of like exposing yourself to bright light in the evening. That might have potential to reset the sleep timing to a later time. Anybody have any questions so far about all that? I know it's a lot in a little bit, but I thought it would be nice to just understand what sleep is and the sleep architecture and physiology. Sure. Yeah. So that's the big debate right now. I think there's a Sunshine Act that is currently on board. So most people I know the Academy of Sleep Medicine also released a statement, and I'm more so on this. If you look at the circadian rhythm and biology, the daylight saving time is counterintuitive to that. What it does, the idea is, and what these circadian experts show is that, if you end up exposing somebody to darkness in the evening and then light in the, darkness in the morning and more light in the evening, that just retimes the body clock to a later time. And there's, I think there are researchers looking at it. They've even published data showing, waking up somebody at a time when now naturally not want to wake up. And that is prone to car accidents, car crashes, daytime sleepiness, and all these negative health consequences that we went over that is associated with sleep deprivation because you're losing that 1 hour. And I think this was in the 1970s, they made this permanent and they had similar situations happen, especially the car crash and the drowsy driving. But that is definitely a debate and hot topic right now. Of course, there's pros and cons of it. Like the con is like, some people don't want to be exposed to that evening darkness because they want to come home from work and do what they need to do. And, want to see where they're going when they're driving home from whatever they have to do, if it's school or work. So it's definitely a big debate, but I'm just a proponent of doing something that matches our circadian rhythm. And definitely both sides of the fence agree that we need one standard time and not switching things because that's dangerous. So now it's just which time to stick with. That's a hot topic right now. With insomnia? Sure. So melatonin is a sedating substances. So for insomnia, it's good for helping you initiate sleep. It works for some people, it does not work for some other people. Again, insomnia, we have to look at the whole picture and see what the person's sleep hygiene is, wake timing. And sometimes we have to adjust their time in sleep to try to retrain the body's clock to readjust to the body environment. So for insomnia, it works for some people, it doesn't work for some people, and it specifically helps with initiating sleep, but not necessarily to keep people asleep. We use it also for the circadian rhythm disorders, like for the delayed sleep-wake phase. We can use it to retrain, to entrain the body clock to try to match up with the sleep environment. Any other questions? Again, insomnia is one of those challenging conditions to deal with. Also, to manage it has to take a comprehensive approach. So there is a cognitive behavior therapy. I don't know if you've tried that. And of course, there's different medications to use for insomnia. Melatonin, somebody asked about that, which doesn't work for most people. Yeah, and that's going back to what I was saying, it helps you go to sleep. And once you go to sleep, you can stay asleep. Some people are opposite, where they just cannot stay asleep. And what I mean by cognitive behavior therapy for insomnia, it's different strategies to use to help you, again, train that body clock to be in a line with the environment. So the cognitive part is just targeting these thoughts that develop over time when somebody has insomnia. Try to make the bed environment comfortable and not so daunting. And then behavioral part, it includes the sleep hygiene that we just went through. There's a stimulus control. That just means keeping the environment only for sleep, like the bedroom only for sleep, and eliminating other activities in bed. In the bedroom, like watching TV, using electronic devices. And then there's a part of it called sleep restriction, where you work with your therapist in a series of ways of figuring out how to retime that body clock. So let's, for example, somebody lays in bed from 9 p.m. to 9 a.m., but they only sleep from 2 to 9. So we restrict that time they're spending in bed, saying, don't go to bed before 2 in the morning. And then by 9 a.m., get up out of bed. And as soon as you get up, the important part is getting exposure to that bright light. And then if they're able to fall asleep a majority of that time in bed, then you gradually increase those hours. But it's a process that takes time. There are certain apps on the phone that has these techniques. So there's certain online programs. And of course, certain psychologists and therapy kind of as a weekly. And I use these techniques with my patients. That's really more important to me versus medication targeting hormone. But at the end of the day, insomnia is challenging. Thank you. Thanks for your question.